Hello nurses, this is Kevin with NursingKAMP.com, and these are my scribble notes on nursing and the NCLEX. Today's focus is on cardiac lecture number 4, angina, two types, stable and variant angina, or Prinzmetal angina. From my sticky note, found on, found on Instagram, Facebook, Pinterest, Etsy, Twitter, and NursingKAMP.com. So what is it? Angina. Angina is chest pain. It's a result of poor blood flow to the coronary arteries. And when we're paving our way to an MI, in a previous lecture I talked about all reasons why a person gets MI, and that's to pave. And the A is the main issue that we're focusing on, and that's the artery. And in the previous lecture we talked about coronary artery disease, and we also talked about two different types: atherosclerosis, which is at the wall, cholesterol buildup, plaques, and also arteriosclerosis, or stretch. Okay, so it can't vasodilate. Both of these can result in an MI. So the first signs and symptoms are, in my cardiovascular disease lecture, I covered, they're kind of asymptomatic. So we look at labs before it happens. But we're talking about angina. And angina is pain, so it is happening. It's an acute situation. So chest pain is always acute. And in my chest pain lecture, I'll talk a little bit more about the treatments, but I'm just kind of differentiating between what's stable versus variant. All right, so there's two different types. So on the heart, you have your coronary arteries. And they're going around and they are feeding the ventricles. Feeding the ventricles O2 blood. And what happens is with stable angina, a person might have cholesterol buildup. Okay? And that cholesterol buildup is in the vessels here. And when they are moving, increase energy, and they are like walking upstairs. And as they're walking up, well, the heart starts to beat faster. And when it starts to beat faster, it requires more oxygen. So in order to get more oxygen, it has to vasodilate to get the more oxygen. Well, sometimes what happens is that blood flow can't get past this cholesterol blockage, atherosclerosis. And that atherosclerosis, it can't really, or an arteriosclerosis, it can't stretch to meet the demand down here. So it can't meet that demand. So then what happens is these cells down here start to say, where's our O2? And they start to get chest pain. And what happens with stable angina is if they stop walking up the stairs and they sit down and then they rest, in stable angina, the pain goes away. Okay? So that's an important concept, because in stable angina, so you say to yourself, well, why do they allow somebody to have stable angina? Well, sometimes it depends on the patient. They might not meet the criteria to go under surgery. So how do you identify that it is angina that's causing it, like stable angina? Well, the person, whatever the event is, they come into the hospital, like, well, I was walking up the stairs and I had some chest pain. I stopped and I came in. Or I was mowing the lawn. That's whatever this is. I was mowing the lawn and I became sweaty and I started having some chest pain. I stopped, I sat down, and then the chest pain went away. Okay? Chest pain that doesn't go away is an MI. Okay, most likely. But chest pain with exertion that goes away when you stop the exertion is stable. So this person comes into the hospital because they were doing this event and they said, I had chest pain over here. So we look at PQRST, pain quality, radiation, all that stuff, to assess that chest pain. See my chest pain lecture. But the principle is that Now all of a sudden we're going to say, okay, let's look at the arteries. So they're going to go for a cabbage. But first they might go on to a stress test. And that stress test will put them on a treadmill. And then we're going to say, hey, let's walk on this treadmill. And let's see if we can get you to have chest pain. Obviously, they're going to be on a monitor. And they're going to monitor that for ST elevations or ST depressions. ST depressions happen first because ST depression says that, uh-oh, the boat is coming. There's a problem. The cells are being starved of oxygen. So any ST elevations or ST depressions on a stress test, you stop the test. Okay? If they start to have chest pain, you stop the test. So we put them on a stress test to evaluate what's going on. Okay? And then whether or not they're going to have chest pain or not. If they do have chest pain, then we're going to say, okay, well, we need to really look at, they stop them and the chest pain goes away. They're like, okay, let's take a look and let's get a cabbage. Coronary artery bypass. Not a cabbage. Cabbage is an actual bypass graft. We're going to basically do a cath, angiocath. And what's going to happen is that now, see my lecture on this. So you can either go into the femoral, where you thread a catheter, or through the radial, or ulnar, radial, into the heart and into the vessels. So you throw this catheter down here to kind of look at what's going. And then what happens is that you might say, hey, wow, there's a blockage. And then what they might do is they might do an atherectomy, where they basically will shave this down. Or they might come up to the cholesterol and they might insert a balloon, and that's balloon angioplasty. Okay? Because they see this blockage. So that's the evaluation of it. And this is also called interventional. So this is interventional cath lab. And what we're trying to do is seeing what kind of occlusion is going on. So what else is there? Is that unstable angina, so they might get interventionals done. They might get atherectomies, they might get plasty, or they also might look at the vessel and they see these cholesterols, and they're like, well, we're going to do some plasty and we're going to put a stent in there. And they might stent them. That depends on the person. So stable angina. So let's get into the different, what it is. So stable angina, is it acute or chronic? Well, it's more chronic because it's not unstable. Unstable angina doesn't go away with rest. How does it start? Well, it's because of underlying CAD, cardiovascular disease. Any labs associated with it? Well, if they have positive troponins, which would mean an MI, that means that there is damage, and that's an MI, but that's not angina. But you do see ST depressions, so that would be with stable angina. Does it affect their eating? Well, not really. They might get nauseous with the stable angina. They might have some, but if they have vomiting is acute, and that's generally MI. All right. Assessment. Well, assessment is that what's the activity before they had the chest pain? Were they walking? Were they walking upstairs? Were they mowing the lawn? If they rested and the chest pain went away, that's stable angina. What's some prescriptions? We'll talk a little bit more about prescriptions, like nitro, in another lecture where I talk about nitrates. But we'll give nitro for stable angina. And the thing with stable angina, if you give nitro and that chest pain goes away, that's stable angina. Okay. When you give nitro and that chest pain doesn't go away, that's unstable angina and possible MI. Another P. What else might you give with stable angina? It depends. You know, they might be on a nitro paste or a nitro patch, or there might be an Imdur. An Imdur is more for variant angina. I'll talk about that next. And then what stands out? Well, stable angina, what stands out about stable angina is that it's more chronic because, you know, they're not having an MI, but all angina could become an MI. The big key is that whatever activity they were doing, when they stop, the chest pain goes away. And that's what is differentiation between stable angina. In my next lecture, I'm going to talk about variant angina and the difference between stable versus variant, and then unstable angina. Well, that's it. My name is Camp, and this is Nursing Camp, and I was just covering stable angina. The next lecture, lecture 25, I'll cover variant angina. We'll see you next time. Now, nurse on.